Welcome back to the Angel Health Podcast. Today, I'm super excited to have Lisa Greaves Taylor. You have such a long resume that I definitely have to look at it, but you are a certified childbirth educator, birth doula, lactation counselor, and a director of the New York City Doula Collective, which is awesome because we've had other folks from the Doula Collective on before. Yeah, so I'd love to know more about your background and why you chose to certify in all of these different arenas. I mean, I know they're all kind of related anyhow. Yeah, but it's just a really interesting, enriching background. So we'd love to know more about what got you interested in the birth space and how you chose to do, especially lactation. I feel like that's kind of a unique perspective to have in addition to being a doula and childbirth educator.
Thank you so much for having me, Catherine. I'm so happy to be here.
Yeah.
And I'm looking forward to talking about the work that you do a little bit as well. It's great work that you're doing.
Thank you.
So I came to birth work as a result of my own two birth experiences, and this was so my youngest is 16 now, and so it was shortly after her birth that I just became passionate. I used to say I caught the birth bug, but then post-pandemic, that feels a little in poor taste.
Okay.
So instead, I just say I became really passionate about all things birth. And so, it was a couple of things that gave me that passion. And so in my first pregnancy, going to birth class with my husband was a game changer. I had my eyes opened to some of, a couple of major things. One being like what a disservice our cultural narrative is doing us, that birth is terrifying and it's this medical drama emergency waiting to happen. And, what a disservice that does us and how important and valuable it is to educate yourself and to have that mindset shift toward being just in awe of birth. That's one thing I learned. And then another major thing that ignited something in me was just learning about how, I'm sure you likely know this now because it's getting a lot more media attention than it was back when I was having my babies almost 19 and 16 years ago. But the U.S. is ranking at the bottom of the developed nations in its outcomes for birthing people.
Right.
And way worse, exponentially worse for Black women and other people of color as well. And so we have a lot of work to do. And I just really wanted to be part of that change. So shortly after my daughter was born, I decided I'm going to pursue certification as a childbirth educator as well as birth doula because I saw that a lot of the requirements for those certifications overlapped. And I was like, that seems efficient to pursue both at the same time. So I have been doing this work now for about 14 years and never looked back and more passionate with every growing day, every passing day. Those were my initial things. And then as I've gone through that work over the years, I've then just in my continuing education decided to also pursue, actually I'm getting a second certification as a lactation counselor right now.
Oh, cool.
About to take the exam this coming weekend.
Wow.
Next weekend.
That's exciting.
And then I'm also an evidence-based birth. I've heard you refer to them before on the podcast. A wonderful organization.
Yeah.
I give all the resources from evidence-based birth to my clients. I teach one of their workshops for earlier in pregnancy. I'm a professional member with them, and I do lots of continuing ed with them. And so in the collective that I direct, that happened about 3 years ago. One of my friends was moving out of the city and she was the director and she invited me to take over, and it's East River Doula Collective is the name of it.
Oh, got it.
Yeah. And so that has been such a life-giving part of the work that I do because we need each other. We need community. And being a doula, being a childbirth educator, any kind of birth worker can be very isolating, just doing it in a silo. And while I was connected to Facebook groups and different things, it's so different to be like in daily community in a WhatsApp group and having Zooms and getting together in person as frequently as we can to support each other, to back each other up, to learn and grow together. So that's been the newest kind of part of the work that I do.
Amazing. So I know you mentioned previously before we were recording, you mentioned that you are not on call as often. So I'm curious how often you now engage with birth, or is it mainly kind of focused on the education side of things?
I teach all the time. I teach like 4 to 6 times a week. And so it's hard for me to be on call. And
Yeah.
so I haven't been on call in a few years, but I am always, staying on top of what's going on in our local hospitals, because there are many of them here in New York
Yeah.
City, and with the doulas in my collective, and, hearing back from my clients that I work with birth class. So those are ways that I keep fresh in terms of like what's going on with our care providers and in the birthing places.
Okay, awesome. Cool. Well, as you know, we are a cord blood bank at AHU Health. So we do cord blood, cord tissue, and placenta banking. So I'd love to get your thoughts when you were working, especially helping assist live births. What was kind of your experience with cord blood banking, and what are your sort of general thoughts on the pros and cons to cord blood banking?
Yeah. I've had students from birth class who've done the banking, and it does come up frequently in birth class. A lot of people ask about it, especially when we talk about third stage of labor and delaying the cord clamping and everything. And a common question is, can I do both, or which should I do if my provider's telling me I can't do both? I think it's wonderful. I think it's really great. And so my kind of spiel that I give in birth class generally is that it has, holds many benefits and more promise, as more research is going to be done. And if someone has in their family lineage some of the known treatable condition or known conditions that we can use this for, then absolutely, and you have the financial ability to invest in this, then absolutely do it. That said, given there are, at this point in time, as far as I understand, fairly limited list, which I know is going to get longer in the future. If they don't have that running in their lineage, then especially if their provider is telling them they have to choose, which I know that like we can do both.
Yeah.
But many people get held up at that, like being told that they can't. And so I'd love to see more education with providers on that topic. Then I would just say maybe err toward the free thing and delay it if they're being told they can't, or like probe a little bit more and say, could we at least just try? You know, if they really want to do it. I'm a big believer in supporting people where they are at, what their preferences are. And so, if someone can afford it, if like money is no object, that's the biggest barrier, of course. And I love hearing, I'd love to hear a little bit more from you about, one of the things I love about Anja that in the little bit I know about you all is it seems like you're really making an effort to make it as accessible as possible.
Yeah.
And that's something that I love because it seems much more like a heart-centered company than the other big cord blood banking companies I've come across. They feel so slick and kind of like it has this a little bit of an ick factor because of that to us birth workers who are so heart-centered in what we do. So I say that all just to say thank you for what you're doing. And I'm really, I'd love to hear more about the accessibility component.
Definitely.
Because I've gleaned a little bit that's a priority for you.
Oh, yeah, definitely. Yeah. I mean, especially because I went to Wellesley. It's a women's college. And I remember like my first kind of exposure to the maternal mortality crisis in the U.S. was through a global public health class that I took at Wellesley. And they have a strong focus on women and gender studies because they're a women's college or a historically women's college. And so, I feel like because of that, I was really drawn to this space, not only because of my brother who had cerebral palsy and my parents were looking for a cord blood treatment for him, but also because of that education I had around things like the maternal mortality crisis. And it made me realize, there are so many people and birth workers that are just really working towards, like you said, like things with a strong passion for it and with their full heart. So so I definitely want to be a part of that as well to the extent that we can. So like the best part I think about what we do is the reviews that are like, you made me feel confident with my birth choices and stuff like that, or just like really informed. So so with that, I wanted accessibility to be a part of that because I wanted parents to feel like it was something that they could consider. So we have financing options for that reason. And of course, I think the best healthcare is free, but we have options starting at $49 a month, which has been able to resonate with some families that felt like there were no cord blood banking options for them prior. So so we're trying to always like get explore different options like insurance coverage, things like that.
And I'm sure it could be challenging when you're first starting a company in the first few years to be able to offer that as much. But I love that that's part of your mission.
Yeah, definitely. And it's interesting because even like really high income parents that we've worked with, they have said things along the lines of like, I just love what like you guys are doing and I love the concept. And we've gotten requests from higher income families to cover the cost for lower income families, which has been interesting. So we've kind of been exploring that too. Yeah, I feel like a lot of people just feel so empowered by birth and what they can do. So even if they have the means to, then they want to help support like other births.
Mm-hmm.
Yeah.
Beautiful. I love it.
Yeah. I'm curious, you mentioned delayed cord clamping. So I'm curious what your thoughts are around delayed cord clamping. Mm-hmm. What is your general recommendation and things like that?
There's this whole thing called a Wait Until White campaign that I love among the like home birth midwives, mostly and birthing center midwives, just letting this idea of letting it run its physiological course and give baby, all this extra iron stores and all the extra blood volume that could potentially help their, support their immune system and support their lifelong health. That's one end of the spectrum that's available to people giving birth at home and in birthing centers. And then in hospitals, the reality is that that's usually not going to be a thing. Mm-hmm. And at least here in New York City, I can't speak for other birthing environments because I've always worked in New York City. AHUG's current recommendation, as I understand it, is 30 to 60 seconds. Mm-hmm. They made a baby step toward a little bit of delayed a few years back. And then World Health Organization recommends up to 3 minutes. And so what I see with my New York clients is that usually they can make a request to wait for 2-3 minutes. And I think you with the cord blood banking, I believe your recommendation is waiting 2 minutes if you want to delay it.
Yes. Yeah.
Right? Because usually then we can get enough.
Right.
blood.
Yeah. Yeah. We say that to just kind of encompass all potential birth outcomes. Like if an umbilical cord is really short and there may not be a lot of blood volume inside of it. Sure. So the 2 minutes is within the safe window. But I remember we've actually worked with birth providers we had one birth provider say that she actually worked with a patient to monitor the cord blood. And the cord in particular was very juicy and thick and long. And so she waited 18 minutes and still got enough blood for us to collect. So
huge range of normal. This is my phrase that I say all the time in birth class. Huge range of normal.
Yeah, definitely. So I definitely wouldn't recommend 18 minutes for every parent, but I think that birth provider in particular was very experienced with cord blood banking. We've been working with her a bit. And so she kind of recognized that there would be enough and used her own discretion. So I think there's potential for it to even be longer than 2 minutes, but generally 2 minutes is within the safe window.
Yeah, and that's in the ballpark of what most hospital OBs are willing to wait up to 3 minutes or so.
Yeah, definitely. Yeah. So I guess you have any general questions about cord blood banking? I know we've covered some, but
I did think, I have multiple, but I'll choose one.
Okay.
And that would be with regard to cord blood, cord tissue, and placenta. Can all of those, at the current time, can all of those be used for the known treatable conditions, or is only one or two of those, or what does that look like?
Yeah. No, they've all been used to treat at least some diseases or things like wound healing, like especially the placenta stem cells are frequently used for skin grafts. And they've also been, there's increasing cardiothoracic use cases. And so, a lot of like cardiologists, like there's one cardiologist in LA that I've chatted with who's really passionate about placenta stem cells in particular. So all of the above can be used today. It just depends on what exactly the particular use case is. Like the patient outcome. So that's why we always kind of say potentially can be used because you never really know. It depends on the physician's discretion.
That's so great to know. And I actually had not heard of placenta banking until I started listening to some of your podcast episodes.
Yeah, definitely.
That's so cool. I didn't know. I knew the other two, but
yeah, for sure. Yeah, we're one of the few cord blood banks that offers placenta banking. So I think it's interesting because I get the sense that in pop culture, there's this fascination with placenta in recent years.
Yeah.
And like the rise in placenta encapsulation. Right. So I feel like a lot of people want to do something with their placenta. So we offer another option for parents to look at. Awesome. Well, I know today we were going to chat about general advocacy, also interventions, particularly medical interventions during birth, and also what childbirth classes look like. So I'd love to dive into some questions around that. So first of all, I wanted to ask if there was any particularly impactful moment for you as a childbirth worker. are a childbirth educator, I think there's a lot of birth stories that highlight sort of the scary parts of birth. So I always try to ask birth providers on this podcast for kind of an enlightening or inspiring story that you've had with birth that we can share with our audience.
Yeah. I mean, the first thing that comes to me is going back to the origins of my, sparking wanting to do birth work.
Yeah.
Was my own to birth experiences. And then since then, starting doing all this work and then starting my podcast and sharing over 100 birth stories so far and counting has also been so educational and I hope helpful. I've heard helpful from my listeners in terms of building confidence and not hearing as much of the scary narrative and more of the empowering narrative. But in my own experience in giving birth, I found that educating myself and my husband educating himself as well, both of us as a pair, and then getting a doula for support were such game changers in terms of having the kind of birth that I had really hoped for.
So you had a doula too while you were a doula, or before you were a doula?
Before I was a doula.
Okay.
Yeah. Both my births were before I was a doula, and so in my first birth, there came a time when it was stalling, and according to my doctor, it was stalling. It wasn't progressing at the rate that we would expect.
Yeah.
And interventions were starting to be recommended. And we used some of the self-advocacy strategies we learned in birth class, and it was a total game changer. I am convinced to this day that if we had not educated ourselves and learned and applied the things we learned, because what good is knowledge if you don't apply it? If the occasion arises for that, I'm convinced we would have ended up with an otherwise avoidable surgical birth. But instead, we use these self-advocacy strategies, which included, asking about benefits and risks and alternatives, and then asking everybody to leave the room was a game changer. Just giving ourselves more privacy, which what we know about the hormones for labor progress is privacy is one of the things that helps oxytocin to promote labor progress.
Interesting.
Why is that?
Yeah.
That's just how oxytocin works in our body is like lovemaking for most of us, we need to be in a private space.
Yeah.
With dim lights.
Yeah.
And that is the same thing that helps labor to progress.
Interesting.
And so that's one of many benefits of asking people to leave the room. And if I had not gone to birth class with my husband and learned that, I never would have known. In our very patriarchal, top-down, doctor knows best society, I never would have known that I could ask anybody to leave the room or even like ask questions or say anything but just, yes, doctor, whatever you say, So we asked everyone to leave the room, and that gave us some time to think about it, to discuss it, in our case, to pray about it. And that's a little doula hack that I give people in class is if you're asking everyone to leave the room, the quickest way to clear a room is to say, we need to pray about it. Whether you're spiritual or not.
Yeah.
We didn't know that doula hack back then. So we just asked people to leave the room and they just sort of slowly left the room. But if you say we need to pray on it, people dash out of the room very fast.
Interesting.
So whether that's authentic or not, that's a little strategy.
Okay, cool.
So yeah, and that allowed time for progress to happen. It allowed also for my doctor to step back from the situation and do a little detective work.
Okay.
And she had a light bulb go off during that time when she was out in the hall.
Yeah.
And she realized, I wonder if the reason that her labor's not progressing is because baby's position. And she was totally right.
Okay.
She came back in. My water broke. I hate to spoiler alert. If you listen to episode 2 of my podcast, we share all the details of this.
Okay, cool.
But it while they were out there, she came back in and my water had broken and she thought we had done it. She thought we had tried to break water, which totally was not the case. It just was this little miracle that I needed to get this second wind because I was at the end of myself. I was about to be give me that epidural and the Pitocin, transfer out of the birthing center at Mount Sinai West here in New York City, which is now closed, sadly. But it was an in-hospital birthing center at the time, and it was a different floor from labor and delivery. So we were going to have to pack up all our things, go upstairs, get settled in a new room, and then get the drugs. My doctor came back in. She had a a technique, a position to get me in to encourage baby to rotate into a better position. He was in posterior, which is facing back instead of facing out. And that leads to slower progress and harder to cope with and more risk of needing a C-section because sometimes babies can fit that way and sometimes they can't. Baby rotated within, I think it was like 40 minutes or so of doing this knee chest position. That's very awkward, but I loved it anyway.
On your back?
No, it's with your head on a pillow and you're like kneeling and your butt up.
Okay.
And it helps I wish I had my little baby doll to show you. But it helps baby to the heavier part of there's the back of their head.
Okay.
And that helps pull them out of the pelvis a little bit to make more space, and then it works with gravity to pull them back down and around. And this is one of many techniques that like we doulas have in our back pocket in case our clients need that to help reposition baby a little bit if we have signs that baby's maybe in posterior position. Anyway, I'm getting really into the weeds with that whole story.
No, that's awesome.
but that was such a game changer because I saw the huge difference that self-advocacy and educating yourself and support too, because we had our doula all along the way, and that was also a game changer.
Okay,
those things made a huge difference.
Yeah, that's interesting. Yeah, I didn't know the aspect about privacy helping. Why does privacy help to speed along birth in some cases? Is it because it's more calming to the nervous system and you just need that kind of serene mind
part
space?
Of it. Yeah, yeah. And oxytocin is at odds with adrenaline and the catecholamines, the fight or flight hormones. And so when strangers are in a space with you, you have a little bit of elevated adrenaline.
Right.
You know, and so the more you are with fewer people and with people you know and trust and even love, the more that oxytocin, that love hormone is going to thrive. And that's what creates those effective contractions.
Yeah. Okay.
Yeah. And we go over all of that in birth class to try to reframe things and help people understand physically what's going on. And then strategically, what do we do with that information?
Yeah. I know it's totally different, but it kind of reminds me of when babies hide when they need to go to the bathroom, even when they're wearing diapers.
Totally.
They need the privacy.
Yeah.
Yeah. My mom said I used to do that a lot.
Yep.
Okay, interesting. So yeah, I'd love to chat about assembling your birth team, especially because you've had so many roles yourself as a lactation specialist and childbirth educator and doula. So yeah, how would you suggest parents choose their birth team? Like in what cases should they look for a childbirth educator versus a lactation specialist, things like that?
Yeah, I mean, there are so many options for a great. And when I think of birth team, we can think about like the big day, and that's probably what we need to plan first. But then surrounding that, what about your prenatal support?
Right.
And what about your postpartum support? Those are equally important. So first, it would be thinking about like what's the birth setting where you're going to feel the safest, and that's going to vary from person to person. And some of that you can't really fully think through until you've like taken a birth class and really educated yourself. And so that's one of the tricky nuances of doing this work is we doulas and childbirth educators are always trying to figure out how can we reach people earlier in pregnancy to help them think through these decisions that you have to make, especially your choice of care provider in birth setting.
Yeah.
You have to make that so early in pregnancy, and it gets harder to switch. The options shrink the later you are in pregnancy. And so that's a really valuable choice. And then, and we have choices between OBs and midwives, and we have midwives who work in hospitals. We have midwives that work in birthing centers and home births. So those are all a whole bunch of different options depending on where you live. We might have different options. And then, of course, thinking about your support. Who's your support person or team going to be? And sometimes that's our significant other, but sometimes it's not. It really depends. I mean, we've come to a point in our culture that I think it's sort of a foregone conclusion that if you have an involved partner, that they're going to be your support partner, but that's not the right dynamic for everyone. Sometimes some birthing people want to have a sister or a mom, like that female energy more so than their intimate partner, or for whatever reason, their intimate partner is just it's not aligned for one or both of them. So that's an important decision. And then thinking about having a birth doula is a really, really valuable decision. We have research on that, proving that it reduces, really indicating that it reduces the need for interventions, including C-sections that are not necessary. It improves birth satisfaction. Yeah, I could go on and on about the benefits of birth doula support, but that's a really important, valuable thing to think about. And that's like for the big day thinking first about that birth team. And then surrounding that, we can think about pelvic physical therapists or occupational therapists. I wish it was standard of care to have at least one consult before birth and at least one consult after birth. In France, that's standard of care, at least postpartum. I have a friend of a friend who's due with a baby right now in Paris. And I want to ask her, is it just after birth? I think it is.
Yeah.
But I would love to hear that they also have prenatal consult. I don't know. That's one thing. Prenatal yoga, how can we optimize, our level of health and fitness and nutrition, maybe working with a nutritionist or a dietitian. Those are just a few that come to mind. Chiropractic, cranial sacral therapy. I'm the resource lady. I love, like, one of my favorite things in life is to be a connector for people and to really help be one of the touch points for building a person's team and support network and community too. And so then lactation consultant, maybe before birth, but certainly after birth, that should also be standard of care. Maybe a mental health therapist, support groups, finding your peers to walk alongside, which is one of the things I love so much about group birth classes, is being able to help them find community. You know, and people who are due in the same, usually the same 3 months or so of each other.
Yeah, definitely.
So those are just a few off the top of my head, a few of the many, many options for your somebody's birth team and perinatal team.
Yeah. Okay, awesome. What would you suggest that people look at first if they just found out that they're pregnant, for instance, and there's so many different varieties of providers you can have. What would you suggest they kind of look into generally? Yeah.
Yeah, so I teach this workshop called it's an evidence-based birth workshop, and it's just a 1-hour virtual workshop, and that's one way that I'm trying to reach people really early in pregnancy, or even when they're just trying to conceive, even better. It's never too early to start one's education, and that helps people start to get some resources on researching where they live and the birth statistics. We don't have data on everything. I wish we had more data. I wish we had more data on what's the rate of induction at different hospitals and with different practices. We don't necessarily, but we do have often C-section rates, episiotomy rates. And a few other things as well. It just depends on the hospital and what they report. But so after I teach that workshop, then I send some of those resources, and so doing a little research on that can be valuable in helping someone think through where they want to give birth. Right. And then once they've picked, is it hospital? And then which hospital? Is it birthing center? Is it home birth? And then that's going to narrow it down in terms of then looking at the care provider options.
Okay. Yeah. Okay, awesome. What do you think someone should look for in a provider, and especially a doula, as a doula yourself? Are there certain questions that you think someone should ask?
I have a whole tip sheet on that I send people after that workshop.
Awesome. You are the resource lady.
Yeah. I'm passionate about it. And most doulas will have a list of suggested questions to ask a provider. And it's really the broadest way I could put it is asking open-ended questions is a smart communication strategy. Yeah. Because you want the provider you're interviewing to kind of give a narrative. Yeah. To get a sense of their vibe. Mm-hmm. And is this your vibe, you who are interviewing this provider? One of many questions I would recommend asking, especially since most of the people I work with are hoping to avoid an avoidable C-section. What is your C-section rate? What is your practice's C-section rate? As you develop your preferences, then figuring out what are the things that matter to you. And again, that's tricky because you're having to do this often way before you've taken a childbirth class, but there's books you can read, there's workshops you can take to help you guide you a little bit in that. Those open-ended questions are very telling, because I always borrowed this from a local colleague with credit to Sarah Ann Lavelle, home birth midwife. She says pink flags almost always turn into red flags. And so now I say that a lot to my clients. If there are ever any tone of condescension or any dismissiveness or any I'm the doctor, why are you questioning me? Even in a tone or just a response, in a way of responding, those things are, I would say, run the other way. I would say, let's look at our other options and see, because I bet there's someone who's more aligned and who's going to treat you more respectfully. Because what we see in terms of satisfaction on the other side of birth, feeling like it was as positive an experience as possible, is not that it goes 100% or according to plan. It almost never does.
Mhm.
It's how we're treated.
Yeah.
And so that just drives home how important it is to align ourselves with a provider with, whom we feel really heard and respected, and like our preferences matter and we matter, and like some trust in our autonomy and our instincts too.
Yeah.
Not just saying this is how we do things and, being given like routine care. That's not what anybody deserves, and that's not improving outcomes.
Yeah, definitely. Yeah, it's been interesting because I moved to New York two-ish months ago. And since then I've been meeting a lot of birth providers, and I always read their Google reviews prior to meeting them. And yeah, some of them have like really, really long negative stories, but some of them have like really, really long, very, very positive stories. And so, yeah, we, especially on the podcast, things like that, like we try to go for providers that have really good reviews and that just have like a sense of warmth. And yeah, like you said, it's never really about, oh, they followed my plan. It's always about, yeah, that they really felt listened to, like that they were able to cater to needs that they felt like they didn't even know they had, things like that.
Yeah. Yeah. And one thing I will mention is I've had so many clients who come to birth class and then as they start to learn, they say, as it said, you can't know what you don't know till you know it. And so a lot of people are like, I had no idea.
Mhm.
Now I'm realizing, I'm starting to ask my provider questions and I'm not feeling aligned. Is it too late to switch? And so then I'm happy to, walk alongside them and hold some space for that and help offer some tips and things. It's almost never too late, at least here in New York City, where we have many, many options. It's almost never too late to switch. And when people do switch, often from a provider who's not hearing them, to most often to the midwifery model of care, night and day. They come back to the next class and they're like, I had no idea that I could be treated as a human being with like so many other aspects to me than just physical health of mom and baby or parent and baby, know? And that just lights me up. That's one of the reasons I'm so passionate about helping people navigate that as early as we can or whenever needed.
Yeah.
Because it really, really, there's so many providers and they're not all the same. And it's a personality fit. A lot of it is, as well as just respect.
Right, definitely. So you mentioned advocacy during your own birth. I'm curious, what are your sort of core principles around what are my rights during birth?
Yeah. So I talk about in class the legal concept of informed consent. I just always want to make it clear, as well as in this earlier workshop, because I want people to understand these concepts as early as possible, that you're never handing over your rights. You're never signing over your rights, because often, so when people are in labor, they get to the labor and delivery unit when they're giving birth in a hospital, of course, and they have to do some paperwork. And I always say, do as much as you can beforehand. But there's always going to be a little paperwork you have to do when you get there.
Yeah.
There is a piece of paper that makes it seem like you're signing your rights away. But any attorney who specializes in informed consent would say that piece of paper that you're signing is not signing your rights away. That would never hold up in a court of law. So I just want people to understand that, because it often can feel that way. And based on the behavior of a lot of our labor and delivery staff here, at least here in New York, they often just do things without informed consent. And that's not technically legal, and that's not what that person deserves. And so I get it. I want to give them some grace. Like, I get it. They're busy. We have busy hospitals in New York area. And so there can be this tendency to just rush through things. And like, I have this checklist of things I have to get done. I'm going to do it without having a conversation. But that's not okay.
Right.
Nothing should ever be done to someone's body. No medication should be given to them. No procedure should be done to them at any point in time without a conversation. Any attorney that specializes in informed consent would talk about this is a process. Legally, it's a process whereby they're supposed to talk you through it. We're saying what they're recommending. And then they're giving the benefits, they're giving the risks, they're giving that person the opportunity to make an informed decision and to provide their informed consent to say yes, or to say no, their informed refusal, and yet that gets skipped a lot. And that's where proactively asking for those things can make a huge, huge difference.
Okay. I've gotten some questions from our own customers around like, how do I mention what I want to my provider? So, yeah, how would you answer that question? If, for instance, it was around cord blood banking, because we get that a lot. How can I talk about this with my provider? Like, yeah, just to make my wishes known. And I feel like generally the advice that I give is that, like, especially cord blood banking is something that you can kind of opt into. And it's more of
Mhm.
like a notice rather than like a request for permission. Like it's just kind of like by the way, like I want to do this.
Mhm.
But yeah, curious to get your thoughts.
Yeah, as much as possible, I highly recommend that people go into each of their prenatal visits with a nice, neat, efficient list of preferences, of
Yeah.
questions, and squeeze a few in to every single appointment. And many times I hear a lot of people tell me that their provider's like, oh, trying to put it off, like, oh, we'll talk about that later at like 36 weeks.
Yeah.
No, thank you. Like, that's another sign to me. That's a pink flag or a red flag to me,
Mhm.
because that's telling me they don't want all those questions
Mm.
and they don't want to hear it. And so, but many providers would entertain that, and I would hope that they would. Anyone I would recommend would do that, because you want to try to. I used to work in event planning many years ago at Harvard, and in event planning, you're trying to do all the things, get all the ducks in a row
Yeah.
before the big day, so that it can go as smoothly as possible and you're not having to, like, it's just on autopilot. And that's kind of my thinking in terms of express those preferences, ask those questions before the big day. That's also one major way to ensure that you've hired the best provider for you.
Right.
So does that answer your question?
Yeah, definitely. Awesome. So specifically while you're giving birth and specifically in a hospital, how do you recommend that folks advocate for themselves? And especially if something is happening that the patient actually doesn't want?
Mhm.
Like, is there recommended language or things like that?
Yeah, we go over quite a bit of that in class. And some things that I would mention are, there are certain words that are kind of like high alert words for a lot of the hospital staff are trained in these words.
Okay.
Such as the highest alert word is safety, or any form of the word safety. Below that would be I'm uncomfortable, I'm concerned.
Mm.
So we call it cuss words. I said it in the reverse order, but it's CUS.
Yeah. Okay.
Say your cuss words.
Yeah.
So that's one strategy. And then I kind of touched a little bit on, there's this BRAIN acronym that a lot of us childbirth educators and doulas have used for education to help it be easier to remember over the years. And so benefits, asking about the benefits, the risks, the options, the alternatives is the A, because there's almost always something else we could consider doing or not doing, for that matter, when it's not an emergency, because it almost never is. And that's an important thing for people to realize, because movies and TV, again, big disservice. Like, everything's emergency, right? And a lot of providers will say we need to talk about doing a C-section, or we need to induce, or do this or that, and it often is communicated in a very urgent tone. And what is the patient here? It's a life or death emergency. I can't even slow down to have a conversation about it. I just have to say yes. It's almost never an emergency. And so that's the first thing to ask is this an emergency? And then usually 99.9% of the time they're going to be like, no, it's not. And then you can take a breath and ask some questions, ask about those benefits, risks, alternatives. And that often takes creativity. And that's another benefit of having a doula, is you have another literal brain in the room with a different kind of training and a different background. And they might have an idea of an alternative that nobody else in the room had. And then I always say that, of this BRAIN acronym, the biggest, best strategic tool, and if you remember nothing else, is buying time. Buying time. That's almost always one of the alternatives or options, is just what happens if we do nothing? Because so much of unnecessary interventions, and when I say interventions, I mean anything that's not physiological birth, medications, technology, and so forth, which have their place, and we're glad we have a lot of all those things when we need them. But we know that, ACOG, American College of Obstetricians and Gynecologists, has stated formally that one of many reasons we are ranking so terribly is not only that we're doing too many C-sections. They said that 10 years ago in 2014, but then a couple of years later, they came out with another report and said, we're also ranking terribly because we're over-medicalizing birth, to sum it up, basically. And a lot of the strategies they gave in that report we're validating all of the Lamaze healthy birth principles that we've been teaching for so long. And so that was really, having a doula for support and a lot of other things as well. And so I digressed a little bit, but yeah, back to the BRAIN acronym. Buying yourself time is a hugely, that and laboring at home for a good long time are two of the biggest, best strategies to have the healthiest birth possible in a, normal situation, which is most people have a pretty healthy, uncomplicated pregnancy.
Yeah.
Yeah.
Okay, awesome. So you touched upon unnecessary C-sections, but when is a C-section considered necessary and when are interventions considered necessary?
Yeah, that's a big question. That's a really big question. So if, say, the baby is, I have somebody in class last night who has a baby who right now is transverse lie, so sideways.
Okay.
A baby literally can't be born through a pelvis in that position. So that's one of many examples of if baby doesn't go head down, by or usually around 36 weeks, then we might need to schedule a C-section. In our country, a breech head up baby is going to, with almost every care provider, be a scheduled C-section, even though that's not necessarily necessary, but it is necessary in our country because we don't train anybody on how to do it safely. It is a different technique. It requires a different skill set. And we just, due to a faulty study years ago on breech birth, they just stopped training doctors in medical school on how to safely catch a breech baby. So that's a scheduled C-section with the vast majority of providers. If we have placenta issues, if the placenta is covering the cervix, later in pregnancy, then that's absolutely, we're thankful that we can have a C-section, have a belly birth, I like to call it, because I always want to de-shame and destigmatize C-sections because there's way too much shame and guilt and sense of failure, which you can't you cannot fail in birth. I just want to really destigmatize that because if it's necessary, it's necessary, and we're thankful that it can save lives.
Right.
But most of our C-sections that happen in our country are really avoidable, preventable ones, and it's major abdominal surgery. So when you think about healthiest long-term outcomes for both the birthing person and the baby, vaginal birth is going to be our goal with that.
Okay. Yeah. What about inductions? When are inductions necessary?
So not as often as they're done here in our country, in my educated opinion. So they are necessary. If somebody develops, the more black and white reasons that off the top of my head come to mind are if someone develops preeclampsia. Absolutely, yes, that could save a life. Yeah, because it tends to get worse. The blood pressure continues to elevate. The protein in the urine is an issue, and that can lead to seizures if the longer we're pregnant. And almost always it cures itself as soon as we give birth. So in that case, we're glad we can induce hypertension. We're concerned that hypertension is going to lead to preeclampsia. Yeah, cholestasis is a little more gray area, but if someone develops that, that's likely going to be more possibly a necessary induction. The most common reasons, though, we have inductions are, and we can talk about the ARRIVE trial if you'd like, is date-based, calendar-based. And that's a lot more of a gray area. And then the second, anecdotally, the second most common reason I see my clients here in New York be induced is low amniotic fluid. Or too high, but that's much less common. It's usually that it's too low. And so now we need to get the baby out. Those are a little based on the research and just evidence that's less clear cut in terms of is that really, really medically indicated. And it's for the healthiest birth possible, it's really only recommended to do an induction if it's truly medically necessary. Right. But with the date induction, it's really you're weighing risk and benefit, and everybody's going to have different risk and benefit tolerance levels, and there's risk with anything we're doing in life, but that's where do you perceive the risk? What is the date-based induction? Is that when they just want their baby born on a certain day? It's the fact that with any care provider, there is going to be a deadline. And if you haven't gone into spontaneous labor by that certain date on the calendar, they're going to say we need to schedule an induction. Now, with our local hospital providers, it's usually going to be somewhere within 39 to 41 weeks.
Okay.
And some of that depends on the person's age and, of course, other medical risk factors as well. And then in a birthing center or home birth, it's going to usually be more generous. Usually we wouldn't talk about induction until 42 weeks or maybe even a little bit later than that.
So if you're kind of overdue in a sense.
Right. Yeah.
Okay.
I wish we would get away from the whole due date terminology because and different countries date it differently. And it's really interesting to look at the evidence-based birth information on that topic because it gives all of the details of how it's calculated here and elsewhere and like what does the data show us in terms of when do people go, what percentage of people go into labor at 39 weeks and 40 and 41. And a lot of us wish that we would shift that due date to be more for primips, for first timers, to be more like 40 weeks and 5 days to 41 weeks and a few days. Cause it's stress inducing whenever people pass their due date, cause now you're late. But like, that's probably what this baby and this parent need for a healthy birth. None of us can know exactly when both parties are ready.
Right.
And the readiness is everything.
Yeah, definitely.
Yeah.
Yeah. Well, I wanted to chat about the ARRIVE trial that you mentioned, as we've chatted about it on our podcast before, and we had quite a strong response around the discussion related to the ARRIVE trial.
I'm not surprised.
Yeah, definitely. So the ARRIVE trial is basically a study that demonstrated that inductions are correlated with lower rates of C-sections, which is really interesting. It was a pretty recent study. I believe it was published in 2017.
Yeah, around 18 or so. Yeah.
Yeah. And so, I guess what is kind of your take on that? Why is it so controversial?
I've taken quite a few classes since that came out with like local respected OBs who have some of the like most satisfied clients and lowest intervention rates, and as well as with evidence-based birth and their analysis of all the research and everything. And the tricky thing, so admittedly, that was a really well-designed, a large randomized trial. And so it's one of the better quality levels of research we have. However, there are a number of issues in terms of like, is that going to translate into better outcomes? Lower C-section rates, lower hypertension rates as well was another thing they were looking at, and better outcomes for babies. They didn't, as far as I understand it, they didn't really see much of an improvement for babies. They did see lowered C-section rates and hypertension rates. But here's some of the nuances to that study. That trial was it's not going to, at least here in New York City, in the way we handle inductions, it's not going to translate into lower C-section rates. One of the demographics were totally different. Those people were way younger than our population skews here. And then even more importantly, they gave people so much time and patience. And just giving people more time is absolutely going to lower C-section rates.
Yeah.
But in New York City hospitals, they're so busy. They don't have that luxury in most cases. And so that's a major, major difference in the conclusions that were made. And those are just a couple of examples. Another thing is that they started a lot of those inductions at home with a Foley balloon. And so, they're going to give people more time if they're not taking up a hospital bed. Okay. We almost never start any induction in New York City area hospitals at home. I've heard of it with a couple of hospital midwives for a hot second and then never again, probably because hospital administration found out about it and their attorneys were like, nope, too much liability. So that's another difference in terms of the patients they were able to, with a CE, they were able to have in those inductions. And there is some research that is budding. It hasn't like made firm conclusions yet, but that along with just anecdotally with my clients and with the doulas in my collective, we're seeing more inductions than ever and more C-sections than ever with those inductions. So I know that's anecdotal. That's not hard research, but I mean, I just know it's compelling. And there is some research that's actually trying to refute the ARRIVE trial conclusions and saying, no, there are other ways that we can way more significantly reduce C-section rates. Yeah. more midwives, and more doula support.
Mhm.
Those are two ways that when we look at the statistics, we see way lower C-section rates.
Okay,
Yeah.
so do you agree that inductions would? I mean, I guess the Arrive trial kind of insinuated that it was more of a correlation, that inductions were correlated with lower rates of C-sections. But do you think that having an induction may necessarily cause having lower C-sections? It seems like no.
Yeah, I don't
Okay.
I don't buy into that at all. No.
Yeah.
And something that can help a lot of people navigate this a little more expertly, a little like to make as informed a decision about
Mhm.
whether or not to agree to an induction as possible, is to talk with their provider about their Bishop's score. If their provider is starting to talk about induction, they're going to be assessing mostly the state of the cervix, and as well as where is the baby, how high or
Mhm.
low in the pelvis is the baby. And that Bishop's score, how high they score or how low they score, is one thing that can help us assess to some degree, at least, how likely is it for an induction to work. And to also have a conversation if someone's agreeing to an induction, to get the lay of the land of what's the roadmap for that induction? What are the
Yeah.
different devices or medications that they generally will use, and what's their general timeframes for these things? Just to help someone feel more confident and at ease and more peaceful going into an induction
Right.
if they do decide that they're going to agree to that.
Okay. What is a Bishop score?
Yeah, it's a 5-point score that I have it on a slide for class. So it is assessing the dilation, how open is the cervix, the bottom of the uterus, the dense fibrous tissue that's keeping the baby in. So how dilated is it? How effaced is it? What's the percentage of thickness versus thinness of it? The position of it. So through pregnancy, the cervix is pointing toward the tailbone for most of pregnancy, and then as it starts to prepare to give birth and let the baby down through it, it changes to mid position and then to anterior, facing toward the vaginal canal in preparation to let the baby out. What else? How soft or firm is it? And then the station of the passenger, which is such a funny clinical term, but the passenger is the baby.
Okay.
And the station is the vertical position in relation to the ischial tuberosities, or the sit bones of the pelvis. And so there's this whole scoring system on that. And the higher someone scores on it, the more ripe and ready the cervix is, the lower the baby is in the pelvis, and the more favorable that bodes for an induction. Well, for them to go into labor spontaneously sooner, or for, if we do need to induce, for it to go pretty efficiently.
Okay. Interesting.
Yeah.
That's a good tip.
Mm-hmm.
I love that you have so many educated takes.
Can you see I'm passionate about this work?
No, I'm learning a lot. And I feel like I'm definitely not like a medical professional by any means, but I feel like just by the nature of working in the birth space, I don't typically learn like a crazy amount of information during a recording, but I'm learning a lot. So yeah, this is great.
Glad.
Yeah, I know we talked about induction, C-sections, things like that, but what are other medical interventions that folks should look out for, potentially just know about, to consider, or to know to avoid?
So one thing that comes to mind is IV fluids. And sometimes that's necessary. If we have any medications, that's going to absolutely be necessary. Monitoring. Going back to IV fluids, though, if someone has had a healthy pregnancy, it's really, really evidence-based to just drink to thirst. And what the research shows us is that either drinking or through IV fluids, that most people need around 1 cup of fluids per hour to help the labor to progress, to have the hydration that they need for a healthy birth.
Mm-hmm.
So yeah, thinking about that. Do you want that, or do you want to drink to thirst? Although in most hospitals, they're not going to just be okay with just drinking to thirst. They might want you to have like a port, a HEP lock, or a saline lock to have quick access in the unlikely event of an emergency.
Yeah.
And then monitoring is another thing. That's an intervention. And again, sometimes necessary, but not always. So, I mean, in any birth setting, we're going to do some degree of monitoring, but the question is how much? And this is something where we do have a lot of research and like good quality randomized controlled trials that show us time and time again that for someone who's had a pretty, healthy pregnancy, there's no major medical indications to need to do continuous monitoring. That continuous monitoring, which is the default in most hospitals, leads to unnecessary interventions like wildfire. Like it leads to knee-jerk reactions because what's probably this baby's version of normal heart tracings leads to, oh my gosh, we have to do a C-section. And so it's really evidence-based for most people to have intermittent monitoring. And really most evidence-based would be just with a handheld Doppler, where they're just putting a little wand on the person's belly and listening to the baby every now and then. And that's usually like every hour if they're with their provider in early labor, every 30 minutes in active labor, and then around every 15 minutes in the pushing stage. That's not really available, at least here in New York City hospitals. That's really not available in most of the hospitals. And like a birthing center and a home birth, that's what they would use. So the way that we can replicate that as closely as we can is to request intermittent monitoring, to have, and what that means is usually 20 minutes on the monitor, 40 minutes off of the monitor. And then you have more mobility, freedom to move around, to go use hydrotherapy in the bathroom, in the shower, the bathtub, to really help progress, because like movement is lubrication. It's helping the baby to come down and helping the labor to progress. And a lot of these interventions, the more we're hooked up to, the more it hinders that ability. And it also is just more comfortable to be able to move around.
Right. Mm-hmm. What can you refuse while pregnant, and should you refuse anything while pregnant?
I really like to get away from the word should in most cases, because everybody has different preferences, and you do have the legal right to refuse anything. Yeah, absolutely. But it goes back to making informed decisions and asking good, smart questions, and whatever questions someone might need to make that decision that feels aligned for them and feels safest and best for them and their baby.
Okay. Awesome. Mm-hmm. The last thing that I want to touch on was general childbirth education, because I believe we've maybe had a few childbirth educators, but you're one of the few that we've had on our podcast. So I would love to touch on what are childbirth education classes, and are they the same as Lamaze classes, and at what stage should you start considering it?
That's the top question on my FAQ on my website is, when should I take birth class? Because that's the most common question I get asked. So childbirth class. So Lamaze classes are childbirth classes, but not all childbirth classes are Lamaze. Okay. I did go ahead and sit for the Lamaze exam quite a few years ago, because I found that lots of people come to you looking for, are you a Lamaze educator? And so I was like, I just need that credential, even though I know I'm equally as competent a teacher. I think it's just useful. It's like the word Kleenex, is like interchangeable with tissue. Same thing with Lamaze.
Yeah, I feel like in movies, I always hear the word Lamaze.
Yeah, it's the household name for birth classes. Right. So, and it's a great organization. Highly recommend Lamaze International and all of their resources. We have a podcast, and so it used to be more of a method. And it's known for its we don't teach that anymore. Okay. Don't do that. You'll hyperventilate if you do that for very long. We really teach evidence-based principles. These healthy birth principles upon which I based my curriculum, which I created. And I'm always adapting to, for my specific New York audience. Those are really based on research and what we see leads to the best, healthiest birth outcomes. Okay. And it's not my childbirth class. So some childbirth classes, there's all kinds of different methods and things, but mine is not fully geared for unmedicated birth, but it's helping people prepare for whatever their scenario or preferences might be, whether that's unmedicated birth. Yeah, we prepare for that if that's what someone wants. We also prepare for epidural birth, or, all the different scenarios. Yeah. And then in terms of, a lot of childbirth classes just prepare for birth, for labor and birth, and offer like newborn care, breastfeeding, other forms of feeding, separate classes. For me, my heart feels most aligned with having it be a journey and having it all be in one longer series. Yeah. To prepare for also postpartum wellness. Really, really important, because we just don't learn about any of that in school, at least in our country. We don't. And it's so important to have that lay of the land, to have some strategies for support and for healing and preventing injury and all the wellness things. Yeah. So my particular mode or setup for childbirth classes is all in one, I call it. Okay. Awesome. And yes, it's a Lamaze class. I feel like there was another question.
It was when should you take childbirth classes?
Thank you. The top question, of course. How could I forget? So I have sort of a complicated answer on that. I would say as early as someone wants. I would say maybe wait till the first trimester is over. But then some people prefer to take it early. And the type of personality that would really benefit from that is the people who feel more at ease and more confident having time to go through all the supplemental podcasts and studies and all the things that I provide in class.
Yeah.
But that's not all personalities. Some people are like, don't give me all that. That stresses me out. And I'm like, you do you. You
Yeah.
just pick and curate the things that work for you and leave the rest. So some people prefer for it to be the information, the education to be as fresh as possible. And for that kind of personality, that's going to be later in pregnancy.
Okay.
Generally, people take it in like early third trimester. That's the most common time that I see people coming to class. But a lot of people wish they had taken it sooner.
Okay.
So those
Good
are some
advice.
things. And a lot of providers, especially hospital OBs, often won't even bring it up until third trimester. And then people are like, oh no, it's so late. Am I going to have time?
Yeah.
Yeah.
Okay, awesome. Cool. Well, I'm curious, what are your top 3 tips if someone just found out that they're pregnant, just to prepare for birth and pregnancy?
Mm-hmm. Educate. So that you can then make those smart choices, build in some really, really great optimal for you support.
Mm-hmm.
And we already talked about the many ways that can look, but including maybe considering a doula. Really going into this whole process, acknowledging that it's very uncontrollable. That's a hard thing for a lot of us in this whole process of becoming parents, this big rite of passage, the unknowable, mysterious nature of birth, and the unknowable nature and uncontrollable nature of having a baby, having a little one now who has their own personality and their own preferences. And so doing whatever cognitive work you can do to make that shift for a lot of type A New Yorkers, achievers. It can be really hard or maybe Californians. I don't know. It can be very hard although you were from Massachusetts originally, right?
No, I went to Wellesley for college, but I grew up in LA. Yeah.
Okay. Yeah. So that cognitive shift of like surrendering to that uncontrollable nature, it can be a really hard one.
Yeah.
And so doing whatever, and you know, I point out that post-pandemic, it is really, we've already had to make peace with that a lot in the early time, like in 2020. A lot of us had this wake up call of like, your idea of being in control in life was all a facade.
Yeah.
It comes crashing down right now. And so like thinking back to what helped you make peace with that, if you were able to, that could translate into really powerfully what it might look like for you to trust the mystery and the uncontrollable nature of this.
Yeah.
So that's a big one. That would be my third one, I think.
Okay, awesome. I love that. Excellent tip. Well, yeah, I really appreciate you being here today. It was a really good discussion. And yeah, like I said, I definitely learned a lot. But if folks want to find you, how can they find you? If they want to do like either your childbirth education classes or anything of that nature, and especially if you want to plug your podcast too.
Sure. Thank you.
Yeah.
It's all Birth Matters. So birthmattersnyc.com is my main website. And then eastriverdoulas.nyc is my collective, but you can also find that at Birth Matters NYC. I'm Birth Matters NYC on Instagram and TikTok and all the places, all the things. I heard you're all over too.
Yes.
Yeah, those are the main ways. And my podcast is called Birth Matters, and you can find that on any podcast player. We are in our current fourth season.
Amazing.
And we have, I mentioned earlier, over 100 birth stories and counting. It's mostly my New York City clients sharing their birth stories.
Amazing.
And then there's also like free childbirth education. So I'm all about accessibility as well. And so that's one way that I have found is a great way to kind of fill in some gaps in what we don't have time for in birth class and learn through the power of storytelling, but also to offer just free childbirth ed based on the different topics that arise. I do some teaching at the end of each birth story. So, that's how people can find me.
Okay, amazing. Well, yeah, thank you so much for being here again. I really appreciate it.
Thank you so much, Catherine. It's been a pleasure.